Okay, so we finished with a fascinating lesion when we were discussing on the first day, and we spoke about transposition, and I told you we didn't need of the great arteries anymore. And the same goes for congenitally corrected transposition. So we can save a few trees if we avoid talking about of the great arteries. So congenitally corrected transposition is the triumph of the sequential segmental approach. In the past, this was considered a very difficult lesion to understand, and in many ways that was because the names we used to describe it were not intuitive. There are probably still some of you who talk about ventricular inversion. I've never seen a patient or a heart when the ventricles are upside down. In fact, what is meant by ventricular inversion is mirror imagery of the ventricular mass, and we will talk about that. When I started in the field, which was 1974, Maurice Lev was one of the best known of the congenital cardiac pathologists, and he was a fascinating, amazing man, but he also used terms that were remarkably difficult to understand. And one of the terms he used was mixed levocardia, and I still don't know precisely what he means by mixed levocardia. Nowadays, there is a penchant for describing this entity for L transposition, and that's okay some of the time, but it's not okay all of the time, and I'll explain that to you. So nowadays, we approach the lesion on the basis of the abnormal junctional connections, and what we're going to discuss over the next 3/4 of an hour or so is the combination of discordant connections at both the atrioventricular and the ventriculo-arterial junctions. We've known about congenitally corrected transposition for quite some time, and this is the man who first illustrated it. This is the Count von Rokitansky, who was the doyen of 19th century cardiac pathologists. He allegedly did over 20,000 autopsies. He was the professor of pathological anatomy at the University of Vienna, and he produced an exquisite atlas. And this is one of the pictures from his atlas, and this is the first illustration of which we are aware, showing us congenitally corrected transposition. Rokitansky didn't call it congenitally corrected transposition, but when you look what's going on, we can see that this is the morphologically right atrium. This is the right-sided morphologically left ventricle with aortic valve in fibrous continuity with the pulmonary valve. This is the left-sided morphologically right ventricle with tricuspid valve that is dilated, almost certainly abstenoid, an aortic valve arising anterior and leftward. And Rokitansky even had the prescience, although he didn't know it at the time, to show you the short axis of the heart as it's now viewed by echocardiographers. So, what we are talking about is abnormal segmental connections. Discordant atrioventricular connections combined with discordant ventriculo-arterial connections. And the very fact that we're talking about discordant atrioventricular connections tells you that we can only have this in usual or mirror-imaged atrial arrangement. You can have a very close cousin in the setting of isomerism, but the specific definition excludes double inlet ventricles as it does isomerism, absence of the connection, and so on. So let's build up what we mean by congenitally corrected transposition. In most instances, the right atrium is where we expect it to be, and the right atrium connects to a ventricle, but the right-sided ventricle is morphologically left. And that then gives rise to the pulmonary trunk, So although the systemic venous return is being driven by the left ventricle, it continues to reach the lungs, which is where it's supposed to go, and hence the circulations are congenitally corrected. So the blood comes back, oxygenated to the left atrium, and then it passes through the Achilles heel of these abnormal circulatory patterns, because it is the morphologically right ventricle that is driving the aorta, and the morphologically right ventricle is not designed to withstand a lifetime of pumping at systemic pressures. So that's the most frequent example of congenitally corrected transposition, but we can also find it when there is mirror imagery of the atrial chambers. Then the morphologically left ventricle will be where expect it to be. There will be right-handed ventricular topology, but still the blood will be returned to the lungs so that the circulations are congenitally corrected. So the morphologically left atrium will be right-sided and will deliver its blood to the right-sided morphologically right ventricle, and that will support a right-sided aorta in most instances, but again, it is going to be the right ventricle, the morphologically right ventricle, that is asked to bear the load of the systemic circulation when the atrial chambers are mirror imaged. So most usually in congenitally corrected transposition, we have mirror imagery of the ventricular mass. And this is the morphologically right ventricle from a nice example of a patient, the heart from a patient who had congenitally corrected transposition. And as you know, we determine ventricular topology by placing the palmar surfaces of our hands on the septal surface of the right ventricle. And so here is my left hand, the dorsal surface of my left hand, and in congenitally corrected transposition, in most instances, it is the thumb of the left hand that goes in the tricuspid valve, and the fingers that go into the aorta, showing us that we're dealing with left-handed ventricular topology. But when congenitally corrected transposition coexists with mirror-imaged atrial arrangement, then the ventricular mass is as we expect it to be. So as you see here, it is then the right hand that goes into the discordant morphologically right ventricle, thumb in the tricuspid valve, fingers in the outlet. So the essence of congenitally corrected transposition in most instances is mirror imagery of the ventricular mass rather than upside downness, but as we will see, we can find congenitally corrected transposition with the ventricles where we expect them to be when it is the atrial chambers that are mirror imaged. But in most instances there is usual atrial arrangement, and then when we take 4-chamber cuts, then posteriorly we can show the right atrium connecting to the right ventricle, the left atrium to the right ventricle. A cut through the middle of the heart shows the left ventricle opening into the pulmonary trunk, and the most anterior cut shows the morphologically right ventricle emptying into the aorta. And this is from a patient, the heart from a patient with intact septal structures. And in some instances, patients with intact septal structures can live a full lifetime and can be discovered as an incidental finding at autopsy. And there are reported cases of 90-year-old individuals surviving with congenitally corrected transposition, but usually that is not the case, because even in the setting of intact septal structures, there are other associated lesions that distort the segmental pattern and point towards a bad prognosis. So we understand it from the anatomy, and here another case, as I recall, with intact septal structures. You can see that this is the right atrium. It has a morphologically right appendage, pectinate muscles to the crux, and it's obviously opening through a morphologically mitral valve, and very nicely we see how the right-sided chamber has a smooth-walled septal surface, and when we fold back the pulmonary leaflet of the mitral valve, we see beautifully those fine crisscrossing apical trabeculations telling us that is the left ventricle. And again, indeed, we have intact septal structures in this heart. We see the mitral valve in fibrous continuity with the leaflets of the pulmonary valve, which is arising from the morphologically left ventricle. Note then the fibrous continuity. Note also this anterior recess of the morphologically left ventricle that is a feature of hearts from patients with congenitally corrected transposition. Now, when we look at the other side of this heart coming from a patient with intact septal structures, we can begin to see why we have the problems. Left atrium, very nicely here, you see the horns of the floor of the flap valve of the ovoforamen. But here we have the problem. Left atrium connecting to the right ventricle, and we have an Ebsteinoid deficiency of the tricuspid valvular leaflet. It is not pure Ebstein, but there is a degree of apical displacement of the septal leaflet with rolled edges. And when we look at the anterior part of the right ventricle, we can see the fibroelastosis, and we can also see a completely muscular subaortic infundibulum lifting the aorta away from the base of the ventricular mass. So if we look at intact hearts with congenitally corrected transposition, then in most instances it is the case that the aortic root is anterior and leftward, but it is not always the case. I've also stated that in a minority of cases, we can have congenitally corrected transposition with mirror-imaged arrangement. So here you're looking at the left-sided heart, and this is the left-sided morphologically right atrium. You can see all the features of the morphologically right atrium. But it again is opening through a mitral valve, but now to the left-sided morphologically left ventricle. And this is the other half of the heart I showed you initially, where we see that the right ventricle accepts the right hand. We have debulboventricular looping, if you will, right-handed ventricular topology. And that is particularly pertinent to the topic of arterial relationships, because we should ask the question. We see L transposition used very frequently, but is it the same as congenitally corrected transposition? And I hope you all know that the answer to that is no. Because the aorta is not always left-sided in the setting of congenitally corrected transposition. We can find left-sided aortas in patients who have regular transposition. And infundibular morphology also varies. So transposition IDD, for example, is congenitally corrected, and it is not L transposition. Transposition SDL is L transposition, but is not congenitally corrected. So we cannot use L transposition as an alternative for congenitally corrected transposition. So I hope you will all now, even though it's a few more words, describe the entity as congenitally corrected transposition. And as I've already intimated, if the septal structures are intact, some patients can live a full lifetime and never come to medical attention. But more usually, there is a triad of associated malformations that serves to uncorrect what nature has been trying to do. And they are a ventricular septal defect, pulmonary stenosis, and anomalies of the tricuspid valve. And then the focus of our attention today has been conduction disturbances. So very frequently in patients with congenitally corrected transposition, we find evidence of abnormal atrioventricular conduction. So how do we deal with these lesions? We deal with them exactly the same way as we would in the otherwise normal heart. So the ventricular septal defect can be perimembranous, muscular, opening to the inlet, to the apical, or to the outlet, and very rarely it can be doubly committed and juxta-arterial. Most usually, the ventricular septal defect is perimembranous. And here you see a large perimembranous defect as seen from the aspect of the morphologically left ventricle. And the feature is fibrous continuity posterior-inferiorly between the leaflets of the pulmonary valve and the tricuspid valve in the left-sided morphologically right ventricle. And the key point for the surgeon in congenitally correct transposition, the conduction axis now runs anterocephalad relative to the ventricular septal defect rather than posterior-inferiorly, as we heard described this morning by Dr. Rayo. In the regular heart, this is the area where you expect to find trouble. In congenitally corrected transposition, the major danger area is the part where, as he pointed out this morning, you usually feel safe if you're dealing with a regular ventricular septal defect. And it was young Quachabur who pointed out that you could pass sutures through to the left side of the ventricular septal defect when you're dealing with usual atrial arrangement and thus avoid damaging the conduction system, although it was Marc de Laval who first made this observation. Pulmonary stenosis. Anything can produce pulmonary stenosis that in the normal heart would produce aortic stenosis. So it can be valvar, we can have a subvalvar fibrous shelf, and particularly in congenitally corrected transposition, we can find tissue tags. And here is a lovely little tissue tag derived from the remnant of the membranous septum that is blowing into the subpulmonary outflow tract because, of course, the left-sided ventricular pressures in the morphologically right ventricle will be higher and will push this tissue tag into the low-pressure pulmonary circulation. Some surgeons, in fact, have unpicked these remnants and have used the tissue to close the ventricular septal defect. It's much more troublesome when you have a subvalvar fibrous diaphragm, as you see here. The valve itself is abnormal on the other side of the diaphragm, and the reason you cannot simply excise such a fibrous diaphragm is that the conduction axis runs through it. And I'll take that back for just a moment, because again, with the eye of faith, you can see the conduction tissue glistening beneath the myocardium. So you cannot resect the fibrous shelf without the risk of producing heart block. Now, in the morning session, we discussed at detail Ebstein's malformation, and we can have an ebstenoid malformation in congenitally corrected transposition. We can also have valvar dysplasia, and, of note, straddling and overriding. We discussed that yesterday. Why don't we deal with straddling valves as a separate entity now? Because they can be found in so many combinations, and in this combination, straddling of the tricuspid valve is a spectrum leading to double inlet left ventricle, and straddling of the mitral valve is a spectrum leading to double inlet right ventricle. I've shown you this picture already, the ebstenoid malformation, rotational displacement, but without thinning of the inlet portion. Equally important, and one of the hearts we're going to look at exemplifies this situation, when you have straddling and overriding of the tricuspid valve, that is associated with gross hypoplasia of the morphologically right ventricle, and likely will rule out the options for biventricular repair. And straddling of the mitral valve, as you see here, can eventually, with sufficient straddling, produce the situation where you have double inlet right ventricle, and now with left-sided, incomplete, posterior-inferior, morphologically left ventricle. There are other associated lesions, and of these, here is a nice example with atrioventricular septal defect. The right-sided ventricular chamber is obviously morphologically left, and you see the bridging leaflets of the common atrioventricular valve bridging across into the left-sided, morphologically right ventricle. Now we have the trifoliate valve on the left side, and that, of course, now should be trifoliate right atrioventricular valve. We can have pulmonary atresia with intact ventricular septum, but now the pulmonary trunk is arising from the morphologically left ventricle, and it is the right-sided morphologically left ventricle that is thick-walled and shows obliteration of the components of its cavity in association here with pulmonary atresia. The coronary arteries reflect the ventricular topology. When we describe them, we need to take note of exactly the same features as we would for transposition with concordant ventricular arterial connections. But there is far less variation in congenitally corrected transposition as in regular transposition. So usually, in the setting of left-handed topology, usual atrial arrangement, the right-sided artery is morphologically left and gives rise to circumflex and anterior interventricular branches, whereas it is the left-sided coronary artery that is morphologically right, and in this instance, the inferior interventricular artery will most usually arise from the left-sided dominant coronary artery. When we have right-handed topology, mirror-imaged atrial arrangement, then the coronary arteries are where you expect them to be, as if it was a normal ventricular mass. We can describe sinusal origin as we would for regular transposition, and the good news in congenitally corrected transposition is that the morphologically left coronary artery arises from the left-handed sinus number 2, whereas the morphologically right coronary artery arises from the right-handed sinus. And as I say, variation in sinusal origin is not nearly as common as in regular transposition. When there are malformations, most frequently it is simply a solitary coronary artery. The focus of our attention throughout today's meeting has been on the conduction system. And in congenitally corrected transposition, we know that there is a grossly abnormal location of the conduction axis. And this depends on two things. It depends on the one hand on ventricular topology, and on the other hand with septal alignment. So when we have mirror-imaged ventricles, L topology, in other words, congenitally corrected transposition with usual atrial arrangement, we expect malalignment between the atrial septum and the ventricular septum, and that is why, as I will show you shortly, we have an abnormal axis. There's been a lot of controversy as to what happens when you have de-looping with congenitally corrected transposition. In other words, mirror-imaged arrangement, right-handed ventricular topology with discordant atrioventricular connections. In this setting, in the cases that have been studied at autopsy, there has usually been pulmonary obstruction. And this has removed the malalignment between the atrial and ventricular septal structures, and that is why, in such cases, there have been described a normal conduction axis, but in association with a sling of conduction system. And so we can illustrate the significance of atrioventricular septal alignment and malalignment if we look at a ventricular septal defect in the heart from a patient with concordant atrioventricular connections. So here we're looking at the right atrium, the aortic valve, and there is the membranous part of the ventricular septum. And as we heard this morning, in this situation, because the wedging of the aortic valve does not disturb the alignment between the atrial and ventricular septal structures, the conduction axis is able to pass directly from the apex of the triangle of Koch to reach the crest of the muscular ventricular septum. And we've discussed that at length this morning. But look what happens in congenitally corrected transposition. Here you are sitting in the apex of the right-sided morphologically left ventricle, and you're looking towards the ventricular base. So this is the mitral valve, and through the mitral valve here, you're seeing the cavity of the right atrium. So this is the smooth septal surface, and that tells us we're dealing with the morphologically left ventricle. And now look how the location of the pulmonary valve produces this malalignment gap and moves the leading edge of the atrial septum away from the crest of the ventricular septum. And then, if you use your eye of faith again, you can see the ventricular conduction system. There it is, on the crest of the ventricular septum. But no longer is this going to be able to reach the regular node at the apex of the triangle of Koch, because that is up here in the atrial septum, and it's separated by the malalignment gap. So instead, we know that there is the ring of tissue that surrounds the tricuspid valve, in this instance the mitral valve, during normal development. So what happens in congenitally corrected transposition is that the conduction axis picks up one of those remnants of atrioventricular ring tissue, and the conduction axis passes in front of the left ventricular outflow tract. And we know that, because in fact, one of the first pieces of work I did, even before I went to Amsterdam and met Anton Becker, when I was working in Liverpool, we serially sectioned a heart from a patient with congenitally corrected transposition. We cut through the subpulmonary outflow tract. We showed the anterior AV node, the anterior bundle, and we showed that the conduction axis passed in front of the pulmonary outflow tract. At the time, we thought we'd made a new contribution, but then we found that in fact a German pathologist called Uher had described the situation in 1934, and then when we went back a little further, we found that Munkeberg had also described it in 1912. So in fact, when I appeared in Amsterdam in 1973, working under the tutelage of Professor Dirk Durre, who was also the mentor for Hein Wellens, Durre greeted me and he said, "You Anglo-Saxons, you spend all the time rediscovering the German literature." And it was indeed the case. But nonetheless, it proved very valuable to me, because my first presentations on the location of the conduction system were given in front of John Kirklin. John Kirklin passed the message on to Dwight Magoon, and because of that, Dwight Magoon invited me to present at the Mayo Clinic, where also I met Gordon Danielson, who we're discussing this morning, and those great leaders of cardiac surgery supported me throughout my career, and it was all down basically to finding this conduction system and rediscovering the German literature. So those of you who are finding your way these days, read the old German literature and you'll find that there are still lots of things still to rediscover. So now we know precisely where we find the conduction axis. If we look from the right atrium, we're looking through the mitral valve. The node is not in the triangle of Koch. The conduction axis arises from an anterolateral node, and there is a very long bundle that passes in front of the subpulmonary outflow tract. and we can see that long bundle if we look from the ventricle. There is the VSD if present, and the anterosuperior bundle extends through that area of mitral to pulmonary fibrous continuity. And that long bundle is particularly prone to fibrosis, and that is why we get progressive heart block, as I'm sure we will hear very shortly. So that's basic congenitally corrected transposition, but oftentimes the relationship are abnormal. That can be due to tilting of the ventricular mass, giving us supra-inferior ventricles, or rotation, giving us this crazy thing, the crisscross heart. So tilting is easy to understand, and oftentimes it's tilted rightwards, and that gives us so-called dextrocardia. We can also have rotation, and the rotation can lead us to the situation where we see a right-sided aorta, even though we have left-handed ventricular topology. And that is due to the twisting of the atrioventricular connections. And my good friend Shi Jun Yu from Toronto now makes the point that it's much better to describe the crisscross heart in terms of twisted atrioventricular connections. We should then not forget that there are close cousins that are not strictly congenitally corrected transposition. Double outlet right ventricle can exist with discordant atrioventricular connections. Rarely you can find discordant AV connections combined with concordant ventriculo-arterial connections. That combination has been given a vast number of horrible terms, such as anatomically corrected malposition or isolated ventricular discordance. I think what we have to do there is simply describe what's going on. And we can also have left-handed topology with isomeric atrial appendages, which will give us mixed atrioventricular connections. So this illustrates the problems that can be produced when you have unusual connections. I hope you will all realize that if you try to put the palmar surfaces of your hands on this ventricular chamber, you can only get your left hand on this morphologically right ventricle. We have left-handed ventricular topology. And it looks at first sight as though this arterial trunk arising from the morphologically right ventricle is an aorta. And in fact, I looked at this heart 2 or 3 times before I realized eventually what was going on. Because here is the other side, and when I now look at it very carefully, I see that in fact the coronary artery is arising from the right-sided arterial trunk, because there are concordant ventriculo-arterial connections. Note in passing that there is also a subaortic infundibulum, but I would simply describe this as discordant atrioventricular connections with concordant ventriculo-arterial connections and parallel arterial trunks. Isolated ventricular discordance, if you will, anatomically corrected malposition, but those names don't tell you anything. We need to know what is going on. It is obviously closely connected to congenitally corrected transposition, but it is the perfect lesion simply to repair with the atrial redirection procedure. So close the VSD and do a Senning procedure. So what do we need to do? Diagnosis now. First, determine the morphology of the segments. Show how they are joined together. What we have said again and again over the past 2 days, you do not infer one feature on the basis of another. We are back to the morphological method. Dr. Van Praag was 100% correct. We should not use one feature in the congenitally malformed heart to try to determine another. All of these features are important: connections, relations, infundibular morphology, but for you as clinicians, it is the connections that determine the clinical presentation, and so it is the connections that should be paramount. So now we have some lovely hearts to demonstrate, so I'll show you congenital